Hello everyone, welcome back to Comment Made Easy, and I hope you all are doing very well. Before we begin, let me remind my dear students that the contents of this channel are only to supplement your knowledge, not to replace the regular online and offline classes in your institution. So please attend your classes and do not miss them. Also, if you like our contents, please subscribe to our YouTube channel, like the videos and share these videos with your friends, with your batchmates, with your juniors. Also, if you are a teacher, then with your students. Please follow our Facebook page and the link will be given in the description. Today we shall continue with the second part of lecture on tuberculosis. Let us start with case finding. That means how we can detect the cases of tuberculosis. So who is considered as a case? A person whose sputum is positive for the bacteria. Target group can be people having symptoms referable to chest. That means chest related symptoms like cough, chest pain, respiratory distress, etc. Along with other symptoms like fever, weight loss, maybe hemoptysis, like this. Intensified TB case finding can be done by community screening or institutional screening. So what is community screening? It is done by inviting people to attend screening at a mobile facility. So there can be a mobile van which is placed at a particular geographical location, and people can attend this mobile van, or fixed facility. Invitations may target specifically people within a given vulnerable group. So we can always target a vulnerable group or people at risk. For example, those who had recent close contact with someone who is diagnosed with TB, or maybe someone having symptoms of tuberculosis. Also, this can be done by going door to door to screen the households. That means members in the family. There is also provision of institutional screening like healthcare facilities, which is done in the hospitals or other healthcare centers. So people having symptoms attending these hospitals or healthcare centers can be screened for tuberculosis. Also, institutional screening can be done in congregate settings. That means places where lot of people stay together or come together for work, like that. For example, shelters, old age homes, refugee camps, correctional facilities like prisons, and other specific locations such as workplaces. So for a certain period of time, or maybe for a prolonged period of time, people come here, stay together, and if any of them have tuberculosis, then since there is overcrowding, a lot of people in this location, so there is high chance of transmission of the infection to the other susceptible people. So that is why institutional screening should also be done in the congregate settings. Now coming to some RNTCP endorsed TB diagnostics. Now again, let me remind you, since we have changed the name to NTEP, National Tuberculosis Elimination Program, from RNTCP, the diagnostic methods, algorithms have not changed as much. So the things that we are doing to identify the cases or to treat them are basically the same. So what are the different diagnostic methods? Smear microscopy for acid-fast bacilli, which is considered as the gold standard method. So sputum smear that can be stained with Jaden stain or Gill-Ninsel stain, or we can also go for fluorescence staining, and it can be examined under direct or indirect microscopy with or without lead. There is also option for culture like solid culture, that is LJ or Lowenstein-Jensen media, or liquid culture like Middlebrook media, using manual, semi-automatic or automatic machines like Bactec, MGIT, etc. Rapid diagnostic molecular test like conventional polymerase chain reaction based line probe assay for MTB complex, that is Mycobacterium tuberculosis complex, and RT-PCR based, that is reverse transcriptase polymerase chain reaction based nucleic acid amplification test for MTB complex like GenExpert. GenExpert is quite commonly used. Radiography like chest X-ray can be done. Tuberculin skin test is not done anymore for diagnosing tuberculosis. Now, for diagnosing a pulmonary tuberculosis, we should first go for sputum examination as well as chest X-ray. Ideally, 2 samples of sputum should be taken. When a person is approached first, or a person comes to the hospital and he should be investigated or tested for tuberculosis, he should give the first sample at the spot, which is known as spot sample. On the next day, he should bring the second sample with him. For that, when he visits on the first day, he is given a container that he takes back home. He should put some sputum in that container in the next early morning, and that sample should be brought to the investigation center. So 2 samples are to be taken, and each sample should contain 2 ml of sputum, and obviously you can do chest X-ray. So in certain situations, the result for different tests can be different. For example, in situation 1, the sputum smear can be positive for the bacteria, and chest X-ray may be suggestive of the tuberculosis. Or in situation 2, the sputum smear is positive, but the chest X-ray findings are not suggestive of tuberculosis. In either cases, since the sputum smear is positive, that means we have identified the bacteria in the sputum, so that is confirmatory of tuberculosis, and we should start the treatment according to guideline. In situation 3 and 4, we can see the sputum smear was negative. That means the sputum does not have any bacteria that we could found microbiologically. In situation 3, the chest X-ray findings were suggestive of tuberculosis, but in situation 4, the chest X-ray findings are not suggestive of tuberculosis. Since the sputum result is negative in both cases, and X-ray is actually not confirmatory for tuberculosis, even though it is suggestive, we have to go for CBNAT, that is cartridge based nucleic acid amplification test. Now for extrapulmonary tuberculosis, the investigation of choice is CBNAT. Alternatively, we can go for LG media culture. What are the advantages of CBNAT? Fast result, so it can be obtained within 2 hours. It also mentions about the sensitivity to rifampicin. We know that rifampicin is a first line drug. We shall discuss about it very soon. So sensitivity to the rifampicin is also known from CBNAT result. And this is the mode of diagnosis in pediatric age group. So if we are suspecting any child having tuberculosis, so we have to go for CBNAT. And of course, this is the investigation of choice for extrapulmonary tuberculosis. So all these are the advantages of CBNAT. Now coming to the diagnostic algorithm for pulmonary tuberculosis, which is actually a very commonly asked long question or part of long question. So I always recommend my students to memorize this diagram or this algorithm. If you understand the concept of this algorithm, it is quite easy to remember. And part of this have already been discussed. So we start with the presumptive TB patient. That means a person having symptoms which can be, or clinical features which can be tuberculosis. So for that, we should start with 2 exams, that is the sputum exam, so smear examination, and chest X-ray. So this is the part that I have already discussed. If the smear is positive and chest X-ray suggestive of tuberculosis, or the smear positive but chest X-ray not suggestive of tuberculosis, it is definitely microbiologically confirmed TB, because we have identified the bacteria in the smear, sputum smear. So that means the person have tuberculosis. So it is confirmed. Now in other situation, when the smear is negative but chest X-ray is suggestive of positive tuberculosis, or the smear is negative or not available, so for any reason the smear examination could not be done, and the chest X-ray is not also suggestive of tuberculosis, or chest X-ray was not done, in both cases we have to go for CBNAT. So you remember this part? This is what we already discussed in this table. Coming back here, and also if there is PL-HIV, that means a person living with HIV infection. So a HIV infected person should always go for CBNAT exam. Now CBNAT exam result, we can detect the tuberculosis. In that case, we go for the rifampicin sensitivity test. You remember the advantages of CBNAT? We mentioned that we could know about the sensitivity to rifampicin. So if the rifampicin sensitive, then that is good. The result can be indeterminate. Then in that case, we have to go for the CBNAT again. So we have to take a second sample and do the CBNAT again. If even on the second sample the result is indeterminate, that means we could not conclude from the result, then we have to collect a fresh sample and we have to go for liquid culture or line probe assay. So alternative method of diagnosis. If the result is rifampicin resistance, then we have to treat the patient like rifampicin resistance tuberculosis. This part will be discussed later. If the CBNAT result, in the CBNAT result, if we could not diagnose or we cannot detect the bacteria, then we have to consider alternate diagnosis. So that may be because of some other causes. So in that case, it can be a clinically diagnosed tuberculosis. That means we could not find it on different examinations like smear examination, chest X-ray or CBNAT. So this is diagnosed tuberculosis based on clinical finding or alternative diagnosis. Now this is the algorithm of pulmonary tuberculosis diagnosis. So this is quite easy if you understand what we are doing here. Now coming to some newer initiatives that have been introduced in the program in recent years. First is daily regimen, then bedaquiline conditional access program. So that means a new drug bedaquiline along with another drug, that is Delamanid, have been introduced in the management of drug resistance tuberculosis. Campaign mode for active case funding, especially a high risk population through house to house visit, especially people at high risk, that are the tribal population, people living in slum, old age homes, prisons, orphanage, etc. And patient wise boxes containing full course of treatment. So there is a box allotted for each patient, and this box contains the drugs that the person or the patient is supposed to take throughout the duration of his course. So what are the anti-tubercular drug? We have first line drug, that is the bactericidal drug and bacteriostatic drug. Bactericidal drug basically kills the bacteria, and bacteriostatic drug, it prevents the multiplication of the bacteria. What are the bactericidal drug? Which have H, R, Z and E. So isoniazid, rifampicin, streptomycin and pyrazinamide. So these four drugs, and ethambutol is the bacteriostatic drug. Often we use these letters H, R, Z, E, S, etc. So it is quite important for all of us to remember what does R mean, what does H mean, etc. So R is rifampicin, H is isoniazid, S is streptomycin, Z is pyrazinamide and E is ethambutol. So these are the first line drugs. We also have the second line drugs like fluoroquinolones. So moxifloxacin, gatifloxacin, levofloxacin, etc. Ethionamide, capreomycin, kanamycin, amikacin, these three are the injectable second line drugs. We also have cycloserine, thiacetazone, macrolide, bedaquiline, Delamanid. So these two have been introduced very recently. We can group the anti-tubercular drug like this. So the first group is the first line oral anti-tubercular drug. So H, R, Z and E. Remember streptomycin, which is one of the bactericidal drugs, is given injectable. So it is an injectable preparation, it is not given orally. And also in recent regimen, streptomycin have been omitted. So we do not give streptomycin anymore as first line management. Okay. In the group 2, we have the injectable anti-tuberculosis agents like streptomycin, as I mentioned. Also you have kanamycin, amikacin, capreomycin. Vaomycin is not very commonly used. Fluoroquinolones are ciprofloxacin, ofloxacin, levofloxacin, moxifloxacin, gatifloxacin. Then we have oral second line anti-tuberculosis drug like ethionamide, prothionamide, cycloserine, terizadone, para-aminosalicylic acid. And group 5 are the agents with unclear efficacy. So not recommended by WHO for routine use in MDRTB patients. So we can have clofazimine, linezolid, amoxicillin clavulanate, thiacetazone, imipenem cilastatin, high dose of isoniazid, clarithromycin, etc. So these are not very commonly used as treatment of drug resistance tuberculosis unless it is absolutely needed. Now let us discuss the two of the newer drugs that have been introduced very recently in the treatment of drug resistance tuberculosis. First one is bedaquiline. So it is a new drug. belonging to the class diarylquinoline. It is a bactericidal drug, that means it kills the bacteria. It targets mycobacterial ATP synthase, which is an enzyme that is essential to supply energy to the bacteria. So if this enzyme ATP synthase is blocked, so that means it cannot produce any more energy, and because of lack of energy, the bacteria will not survive. Now, who are the pupillar patients who are eligible for bedaquiline therapy? So, multidrug resistance or rifampicin resistant tuberculosis with resistance to any or all of fluoroquinolones like moxifloxacin, gatifloxacin, levofloxacin, etc., or to any or all of the second line injectable drugs, amikacin, kanamycin, capreomycin, etc. In case of extensively drug resistance tuberculosis, in case of mixed pattern resistance tuberculosis, so XDRTB along with additional first line or second line drug resistance, and also treatment failure of MDRTB with fluoroquinolone or second line injectable resistance or XDRTB. So in all these cases, bedaquiline can be added. The second drug is Delamanid. That is the first approved drug belonging to the class nitro-dihydroimidazole oxazole for the treatment of multidrug resistance tuberculosis. What is the mechanism of action? It is also another bactericidal drug. It acts by blocking the synthesis of mycolic acid, which is the building block for the cell wall of the bacteria. So if the drug blocks the synthesis of mycolic acid, that means the cell wall of the bacteria will be defective. Now the drug introduces nitric oxide through this defective cell wall. So if you remember the class nitro-dihydrous, we have a nitro group here. So nitric oxide is introduced through this defective cell wall, which then metabolizes the bacteria. So as you can understand, first it causes synthesis of defective cell wall, then it introduces nitric oxide through this defective cell wall and kills the bacteria. So that is how Delamanid works. We have Delamanid capsule, that is a 50 milligram enteric coated capsule, and it is given as a part of appropriate combination regimen for pulmonary multidrug resistance tuberculosis in adult patients, when an effective treatment regimen cannot otherwise be composed for reasons of resistance or tolerability. So when other regimen for multidrug resistance tuberculosis do not work because of resistance or they are not tolerable, in that case we can include Delamanid as a part of combination for treatment of MDRTB. Now let us look at some of the inclusion criteria for these new drugs, bedaquiline and Delamanid. So any patient aged more than 6 years having MDR or RRTB, that is multidrug resistance and rifampicin resistance tuberculosis. Ideally, Delamanid and bedaquiline both should be given to patients who are 18 years or above. But Delamanid can be given at earlier age group, like for children above 6 years or in adolescents from 6 to 17 years. Whether bedaquiline to be used in 6 to 17 years age group or Delamanid should be used in 3 to 6 years age group, it has to be considered only after it is approved by the DCGI, that is Drug Controller General of India. Another criterion is non-pregnant females or females not on hormonal birth control methods. So if anyone is pregnant or anyone is following a birth control method that is based on hormonal therapy, they are not ideal candidate for taking bedaquiline or Delamanid. They should be willing to continue practicing birth control method, which is non-hormonal obviously, throughout the treatment period, or they have been postmenopausal for last 2 years. Now, patients with controlled stable arrhythmia can be considered after obtaining cardiac consultation, because these drugs are known to cause arrhythmia or aggravate arrhythmia. So the person has to be stable cardiologically. So if there is any arrhythmia, he has to be stable. What are the exclusion criteria for the newer drugs? Pregnancy and lactating mothers currently having uncontrolled cardiac arrhythmia that required medication. Having any of the following QTC interval characteristic of screening. যেমন for example corrected QTC more than 500 at baseline and normal electrolyte. ECG to be repeated after 6 hours, and if both ECGs show corrected QT more than 500, then the patient should not be challenged with cardiotoxic drugs like bedaquiline, Delamanid. So that means you have to go for the ECG, and we have to do 2 ECG at 6 hours gap, and in both of them showing the corrected QT interval of more than 500, then it should not be given. Also, history of additional risk factors of torsades pointes, for example heart failure, hypokalemia, family history of long QT syndrome, etc. So as you can see, lot of ECG findings we have to look for, and if there is any arrhythmia or any finding related to heart that can be aggravated by the drugs, then the drugs should not be given. Now coming to treatment category, this is very important, and I have seen students still making the mistakes even in the recent years. So earlier we had new cases and previously treated cases. Now we do not follow this criteria or classification. Now we have drug sensitive tuberculosis, that means the bacteria is sensitive to the first line drug, and then we have drug resistant tuberculosis. Now according to previous regimen, when we had new cases and previously treated cases, these were the regimen. So we had intensive phase and continuation phase. Intensive phase is of shorter duration, so as you can see 2 and 2 and 1, and continuation phase is for longer duration. So let me just explain here something. You can see certain numbers before the digits. You already know what HRJDS means. So isoniazid, rifampicin, pyrazinamide, ethambutol, and streptomycin, right? So this first number we have is the number of month for the phase. So since we have 2 here, so that means intensive phase in new patient has to be continued for 2 months, whereas for previously treated case intensive phase is 2 months plus 1 month, so total of 3 months. Continuation phase is 4 months in new cases and 5 months for previously treated cases. There is another number after the letters here or name of the drugs here, that is 3. So ideally what we used to do earlier in previous regimen, we used to give these drugs 3 days a week, so every alternate day. So that is why 3 was mentioned here. Now that is the concept of intensive phase, continuation phase, and the regimen, previous regimen that we had. But right now we do not have this regimen, so none of these are valid now. So please do not write this regimen in your answer, that will be a wrong answer. Now at present we are using this regimen for all tuberculosis patients, provided we are talking about drug sensitive tuberculosis. So drug sensitive tuberculosis, so all cases, that can be new case or previously treated cases. So the intensive phase is 2 months of HRZE, isoniazid, rifampicin, pyrazinamide, and ethambutol, and continuation phase is 4 months of HRE, that is isoniazid, rifampicin, and ethambutol. So there is no pyrazinamide. As you can see, there is no 3 or any number after the name of the drugs. So that means now the drugs are not given 3 days a week, rather it is given daily. So as you can say 7 days a week. So that is why no numbers or digits are given after the name of the drugs. So that is why we call it daily dose regimen. So please remember, if a patient is having drug sensitive tuberculosis, this is the only regimen that has to be followed. So this is intensive phase for 2 months, continuation phase for 4 months, and all the drugs are to be given on daily basis. So this is the 4 FDC, that means fixed drug combination, which is given during the intensive phase. I think you cannot say this, but the name of the drugs are given here: rifampicin, isoniazid, pyrazinamide, and ethambutol. So HR, Z, and E. And this is the 3 drug FDC, which is the drug for continuation phase. So rifampicin, isoniazid and ethambutol. This is what the strip look like. Now let us look at some of the advantages of the fixed drug combination therapy. First is simplicity of treatment, because now we have only one regimen, and also a single tablet have all the compositions, all the drugs inside it. So increased patient acceptance because fewer tablets to swallow. Now a single tablet have all the drugs. The patient does not have to swallow multiple tablets. Also prevents concealed irregularity, because earlier patient had to take this drug on alternative day, because 3 days a week regimen. So often they would forget taking the drug. Now since they have to take the drug on daily basis, it is very unlikely they will forget to do something that they are supposed to do daily. So we can also prevent some irregularity. It also increases the compliance, so health worker compliance, because now for the health workers it is very easy to handle fewer number of tablets, and that also helps in quicker supervision of the dots. Easier drug management, same thing. Now we are handling less number of drugs, less number of tablets, and also there is only one regimen to be followed. Reduced use of monotherapy, lower risk of misuse of single drug, and because of that we can also lower the risk of emergence of drug resistance. Easier to adjust dosage by body weight. So based on the body weight, the regimen, the drug remains same, but the number of drug that has to be taken changes. That we shall discuss next. So as you can see, the daily dose schedule for adults. Now we are talking about adults as per weight bands. Now this is the latest schedule. In previous edition of PERC, the schedule was different. Now this is the currently used schedule. We have the weight category here, 25 to 34 kg, 35 to 49 kg, like this. So in intensive phase, there are 4 drugs. Each tablet contains 75 milligram of isoniazid, 150 milligram of rifampicin, 400 milligram of pyrazinamide, and 275 milligram of ethambutol. This is the combination for continuation phase. So HRE. Now if a person belong to the body weight of 25 to 34 kg, he is supposed to take 2 tablets during the intensive phase, and also 2 tablets during the continuation phase. So as you can see, if the body weight increases, the number of tablet he has to take now also increases. Now remember, suppose someone is above 75 kg weight, you may think that he has to take 6 tablets right now. But remember, if these drugs were available in different or separate tablets, that means for this regimen he had to take 4 into 6, that is 24 tablets. Now he has to take only 6 tablets, which is quite more convenient. So of course the fixed drug combination makes it convenient for the patients to take the drugs. If a person, an adult person, weighs less than 25 kg, which is very uncommon, he will be given loose drugs as per body weight. So in that case we cannot give the fixed drug combination. Based on the body weight, he has to be given separate drugs for the separate combination. And this is the fixed drug combination for pediatric age group. Same again, the body weight classes are given here, and how many drug to be taken, that is also given here. So with this we conclude today's session. Today we have discussed some very important things, like how to diagnose tuberculosis, what is the algorithm that should be followed, what are the different diagnostic methods, and what are the advantages of some of these methods. Then we talked about some of the newer initiatives, which we shall obviously continue in our next class. We talked about the 2 new drugs that have been introduced, what are the indication, what are the contraindication of using those drugs, and then we talked about the regimen for the drug sensitive tuberculosis and how these drugs are given, what are the dosage to be followed, and how it is followed based on the body weight. So if you like our video, please subscribe to our channel and also share this video with your batchmates, juniors and friends from other colleges. We also have our Facebook page that you can follow. The link is given in the description. Take care, and we shall see you in our next video.